Oh, hey, Chris.
Hey Chuck, how are you?
Good, good. Good morning.
Good morning. Now we're changing up. Last time we recorded on a Saturday afternoon. This time it's a Friday morning before everything gets started.
Yeah, I biked into work, which I'm able to do again now, which I can't tell you the mental health benefits of doing this. So I'm happy.
So what are we, 3 months post-op?
3 months post-op. Yeah.
How's the range of motion?
Range of motion is great. Um, the limp comes and goes. End of the day, it's back. I don't know. Knee replacement is, I think everything you hear is true. It's not as easy as you think it might be, and it takes a while.
Do you think I mean, you had a partial. Do you think the number is still 80% of or 20% of people who have a total knee are unhappy? Like that's a number that's often quoted based on the literature from the mid 2000s, I think.
It's funny. I was on my mission trip and people were, sort of laughing at me talking about it. And I'm like, I thought everybody did well eventually. And they're like, no, they were quoting 30% of people are not particularly, not thrilled with their results. 30.
Yeah, I mean that's a lot of people, right? As opposed to a total hip replacement, which, by and large people love.
Yeah. Like hips are like 95%. Knees, I think knees are higher than that, but I don't know what the modern day numbers are.
Here we are, two hand surgeons talking about outcomes after hip and knee replacement.
Maybe I should have known more before the surgery.
Maybe we should get your surgeon, Dr. Nunley, back on the podcast to discuss that for us.
Yes, I'm sure his numbers look different.
All right, big day today. A lot of cases or clinic or what? What's going on?
Mixture of the above. A couple cases. I have the COH clinic today, which is busy before the holiday weekend, and some admin. What about you?
Okay. All right. Well, I got another raging clinic before going out of town. It's always that like, before you go out of town and after you go out of town. The last every email I've gotten about having a patient come back, I'm like, just make sure it's not the week after I get back because that's going to be insane. So yeah, just clinic today and gonna fly out and have a good time. So yeah, it's always fun to have that kind of day.
And you're gone for 2 weeks?
No, just a week.
Just week.
Just a
And you
week
leave this weekend?
tonight.
Oh, you
Yeah,
got to crank. Let's get this
yeah.
episode done.
So yeah, I think this is I guess now an annual tradition. This is our what's new in hand surgery. I think this will be part one of two, but let's see how far we get. So I used to write this article actually a few years ago for Journal of Bone and Joint Surgery, and it really kept me on top of the literature. And in a I guess like a masochistic way, I kind of miss it a little bit because I had all the articles from like JHS European, Hand. I had all the abstracts and everything pulled up, and it was just like this process every year of like whittling it down. An incredible amount of time. So shout out to Deb Bohn at in Minneapolis for doing it for the last 3 years.
It is it is absolutely as you state. It is a labor, but it is an important one, both for everyone who reads the article, but for each of us individually. I've done something similar in two forums for pediatric congenital years ago. More importantly, every year for the last, I think it's 10 years now, we've awarded the Paul Mansky Best Congenital Manuscript, and that requires a review of 7 major journals to identify articles, and then myself and Deb's partner, Ann Van Heest, and Michelle James review them carefully and award a winner each year with recognition. So it's a valuable exercise.
And I think all three of you have junior partners that you maybe are going to be passing that on to at some point. Because isn't Michelle semi-retired or retired, and you have an incredible partner who is now a full professor who maybe could help you out with that.
Yeah, I try to be careful not give her too many quote unquote opportunities. Michelle has retired from the Sacramento Shrine and is working at UC Davis, I think, trying to reboot their fellowship, actually.
Okay, well, I think that's a task, and that's going to be an exciting ride for her. Yes, classic Dr. Gelberman reference to quote opportunities. Yes. So yeah, no, I
Yes.
I love I love reading the what's new in hand surgery, and I think it's something that is important to keep up with, and I think there are a few articles I'm going to pull from this after reading just this brief summary.
Well, yeah, I love that. And there are some stimulating articles, and I think you do a great job driving this conversation. So let's get to it.
Thank you for that opportunity, Chuck. But before we dive in, we should talk about our friends over at Practice Link. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/theupperhand.
So funny. I was talking to somebody about the podcast recently, and I was like, "Yeah, essentially it's 99% one take, and hopefully very minimal editing from Chuck since he has to do the editing." So I don't know if you're going to edit that part out or not. But and
No,
I will say, Deb, there is no nerve section here. So I know that you wrote this for the practicing orthopedic surgeon, but they see nerves too. Just saying. Anyway,
yeah.
we'll dive
Well,
right
I
in.
I think it's fair enough because I'm thinking back at some of your year-end summaries, and I don't remember seeing a lot of peds in all of them.
I
So
put as much peds in here as she put in here, to be honest with you. It got 3 paragraphs in this year, so that's pretty much what I did too.
fair enough. Yeah, no nerve. No nerve. Wow.
I know, I kept reading, waiting for it, and it didn't come. So anyway, trigger finger, very common condition. As she states here, a straightforward condition to manage. There's one article that they pulled here, that Deb pulled here about the dosing of steroid injections. So 5, 10, or 20 milligrams of Kenalog, triamcinolone is the generic name, and they found a dose-dependent response. Have you noticed a difference? Honestly, my cocktail for my injections is based on what I saw in fellowship. So how did you guys arrive at that cocktail?
Good question. This is one of those things in hand surgery passed down. This is what I used in fellowship, and I used Depomedrol, which I believe is longer acting. I have personally, honestly, ashamedly, no reasoning behind my cocktail.
Yeah, well, I mean, it seems to work for us. I mean, we've never really needed to re-examine it. I mean, um is this something maybe we'd want to consider adjusting the cocktail? And I know that I don't believe we buffer our lidocaine, do we?
We went through a phase where we did buffer. I don't think any one of us buffers anymore because we just didn't find meaningful impact on discomfort.
Right, and it's just another step for the person preparing the injection.
Just another step. And I think one of the things we do, it doesn't make it right, but one of the things we do is try to make things really easy on those helping us in clinic. So we like to be standardized because our MAs and nurses rotate, and we have the same injection protocol for every single injection, no matter where we're giving it, right? And for a trigger finger, we may give less of it, depending on the situation, but it's the same, draw up the same meds for every injection.
Yeah, the meds are basically the same. It's just I personally don't think I can get more than a total of a cc into a trigger finger before causing discomfort, and that's kind of half lidocaine with the steroid. I don't know what your sense is. There's kind of like a touch to it where you've filled, and then you see the grimace when you've gone too far.
Yeah, when I do a trigger injection, I give an injection just a tiny bit under the skin, go a little deeper right around the pulley, and then I tell the patient they're going to feel fullness going out towards the finger, which happens about 80% of the time where you can, and I always have a thumb on the finger near the A2 pulley and you can feel it. I tend to think that makes me feel better that it's going to work. Of course, there's no science there either.
Do you think you need to get into the sheath?
No, and
Because
there is.
I think there is a paper showing you don't need to be in the sheath, right?
Yeah, all you need to do is be around the sheath, which is pretty hard not to accomplish.
Right, exactly. And when this is getting veering from the review article, but I think this is like practical aspects of injection. So where do you inject? So we're on YouTube, so show people where you put your injection.
So I've tried every different way. I've gone all the way to the palmodigital crease and aimed proximally. I've gone a little proximal to the DPC. I inject right over the friggin' A1 pulley now. No, just do it right there. What about you?
I'm the same. I think one of our partners injects at the Palmer Digital Crease. So when people come in and have had injections by somebody else in our practice, they're kind of expecting it to be a little more distal. But I tell them this is where it gets hung up. So I go. There was a nice study that Scott Wolf would quote that when they were looking at percutaneous trigger finger injections or trigger finger releases, they found where the A1 pulley is relative to surface landmarks and for our residents and fellows, see that, when you go from the distance between the palmar digital crease and the PIP crease, and you translate that distance proximally, that's where the leading edge of the A1 pulley is. So that's where I go.
I use that landmark as well. I think it's an important one. And then I'll say one other thing. I don't believe in 2 injections because there definitely are people who will give a small lidocaine injection with a separate syringe and a separate needle and then switch. Makes no sense to me at all.
Well, I mean, I fondly refer to that protocol as the Gelberman injection, because that's what I did with Dr. Gelberman. And there are certain people in our still in the practice who still request the way that Dr. Gelberman did it. So I'll do it. And some of that is our team members, our staff, who request a Gelberman injection. It does add a lot of time to your workflow, though, for sure.
And I don't think any patient benefit. And then the only other thing is, the cold spray. I will use ethyl chloride when the patient requests it. I don't personally think it makes a big difference, but some people swear by it.
I think it's the psychological aspects of it, but it is, there's the pain from the needle going, and then there's the true pain, I think, from the injection is when the injectate is being is filling the sheath or is filling the palm, and that's where I think you have no control over that aside from the pace and the amount that you inject.
Yeah, yes, I love the timeline discussion next that Deb hit on. I thought that's super interesting.
Yeah, so she mentioned an article that was from Bitar et al. And what do you tell patients about how long it takes to see relief from a trigger finger injection? Because this is different than what I usually tell people.
This is different than what I tell people as well, and I guess therefore we should share. So what she cites from the Bitar et al. Is that the timing of symptom abatement with pain relief at 9 to 11 days, improvement in stiffness at 11 to 15 days, and resolution of triggering at roughly 3 weeks from an injection. And of course, we don't know what we don't know. And if we don't ask the questions or see the patient back, we don't know. I tell patients that, some will wake up in the next day or 48 hours later and have relief. I think others will take 2 to 3 weeks, and that's what I tell them. But I have never heard or personally recognized this kind of timing for symptom relief. Fascinating.
Yeah, no, I think this is great. This is really helpful for counseling. I'll probably adjust my counseling based on this because I usually tell people, just roughly, the steroid takes 2 or 3 days to kick in, you start to feel better, and I've seen it take up to 1 to 2 weeks in a few patients. So clearly, I am wrong in my counseling, or at least the patients that are in this RCT from Europe are different than the patients here in good old San Luis. But I have asked patients at times, how long did it take to kick in? And, I guess I probably should ask in more detail.
Yeah, I think the major take home is don't downplay this. Don't make it seem like it's going to be 3 or 4 days. You're gonna be fine in 3 or 4 days. That's not true. We know that's not true. And obviously, with the symptoms they're describing, stiffness, and these are more significant triggers that they're injecting and they're citing. So every trigger finger is not the same either.
Can you imagine randomizing patients to a study for trigger finger? That's got to be talk about adding time.
As I've told you, I've done my last randomized controlled trial with the CMC paper.
Kudos to you, sir.
Yes.
So Deb then goes on to talk about trigger finger release. It says in here that dogma suggests that the A0 fibers should be released along with the A1 pulley. I always thought that was kind of a very WashU-centric thing to talk about releasing the palmar aponeurosis pulley that Dr. Mansky described, which I'm assuming is the same as the A0 pulley. So did you see elsewhere in Cincinnati, were they releasing the palmar aponeurosis pulley in fellowship?
Yeah, so first of all, I think that's a good shout out. Dr. Mansky did describe the PA pulley, the palmar aponeurosis pulley. I assume this has to be that, and like you, I definitely do that. I release the entire A1 pulley. I release at least the distal half of the PA pulley. Occasionally, a few fibers from A2. In Cincinnati, it was mixed. Some did and some didn't. That is, some did release the PA pulley, the A0 pulley, and some did not.
Well, this study shows that you should be doing both. So yet another RCT for trigger finger patients, but showing that, half of them had resolution if you release only A0, about half had resolution if you release only A1, but all of them had resolution if you've released both.
I mean, these numbers are crazy. First of all, that they did a trigger surgery and only released A0. And again, I'm not being critical. I'm admiring what they were able to pull off. I don't know that we would have designed a study in a similar way, but this is really important information.
I don't think we could have gotten this through our IRB, to be honest with you, because I don't think there's enough equipoise. But clearly, it's there are people interested in this that have found the evidence suggesting that you could only release A0 and have somewhat similar results. But I think the RCT is the proof's in the pudding.
So A0 and A1 is the our continuing technique.
Correct. And keeping on the theme of recovery taking longer than what we expect, the group up at Brigham, Phil Blazer's group, looked at how long it takes to recover after trigger finger surgery. The interesting thing to me is that patients, the median self-reported full recovery was 6 months. I don't honestly, I don't see them beyond 2 weeks, if that. So what do you think how do you think that reflects on your practice?
Well, the first thing I think is it makes me feel better about my knee replacement. But wow, again, I mean, maybe it's they're 80% better at 2 weeks, like you said, and then it just takes a while and it's always the when do you stop thinking about the procedure or the spot or whatever. This is incredible, and obviously Phil's group does great work, and this is a study I will obviously trust and absolutely quote. This is important.
Yeah, no, I think it's helpful to tell patients it's going to take longer than both, you and I anticipate and want. And what's interesting to me is that 4 out of 50, so 8%, had not reported full recovery by 12 months. Now that's shocking to me, to be honest with you. I don't know how much of that is, the specific population that they're seeing up in Boston. Maybe that influences it. Uh, that has not been my experience, and I'll be honest with you. I don't think the self-reported recovery is 6 months in St. Louis.
Again, we don't know what we don't know, but I don't either. But maybe we've been burying our head in the sand, or maybe your patients are coming to me and my patients are going to you.
Right, right. Well, incoming fellows, maybe you have a research project coming up. I don't know if I want to do anything in trigger finger though.
Yeah. Well, to beat a dead horse, actually, clearly this is new information, so maybe it's not a dead horse. Um, this study about the risk of complications is also interesting, and I will say this. I don't want to say this mirrors my experience, but I think we as hand surgeons tend to downplay the risk of less than perfect outcomes after trigger release.
So I would agree with that. I mean, what do you think are the things that we downplay?
I think we downplay the risk of scar tissue and continued discomfort. And I think I don't know, it was like, I don't think we downplay infection or, things like that. But I just think it's not as simple a surgery as, we can deceive ourselves into believing. It is a simple surgery to perform. It's a safe surgery to perform. In my experience, there's a real population that has recurrence or triggering, and it's probably in my hands. 5%. I really think it's that high where I either do another injection or super rarely do another surgery.
Yeah, I think that's well said. I mean, I think there are some patients beyond the recurrence of triggering that just have ongoing discomfort. Some of that is, stratification of, who's more severe when they come in. We read an article in Journal Club recently, our hand service journal club, about, PIP contractors, truly being a poor prognosticator, as classically taught and, evidenced in the recent papers. And I think the scar tenderness is a real thing. It doesn't happen often for me, but I always counsel patients about the possibility of a painful scar just because of one patient I have in mind that's had a painful scar. Uh, and has let me know in online reviews. So that stays front of mind for me.
A patient's painful scar is a surgeon or injector's painful scar as well. I mean, it is true. And, as I tell patients all the time, this is something that we can't control. Scar massage and modalities can help. Eventually we'll be able to control the development of scar tissue. Right now, we just can't.
Right, absolutely. So before we get into the best part of the article, at least the one about compressive neuropathy, we should pause and thank our friends over at Checkpoint.
We should.
Truly a pause, Chuck.
A real pause. The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. As a hand surgeon, you know that nerves matter.
It's why Checkpoint Surgical is singularly focused on elevating the clinical practice of peripheral nerve surgery with innovative technologies that help improve patient outcomes. Checkpoint Surgical's portfolio includes a range of handheld intraoperative nerve stimulators, nerve cutting instruments, and biomaterials.
To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical driving innovation in hand surgery. What I love about Checkpoint is they do change up the content, which is clearly evident to everyone listening right now.
Yeah, so when I was talking about the podcast a few weeks ago in Houston, I was telling them that I listened to the pod as essentially quality control just to kind of know, and then also so I know what I say because sometimes I forget. But I listened to it at 1.5x. So maybe that pause right before you started the coffee. It doesn't seem that long when you're listening. Maybe some people listen to us at 2x. We sound like chipmunks. I don't know.
Well, when I listen to regular podcasts, I listen at typically 1.5. 1.0 is just too slow. No one out there listens to you and me at 1.0.
I think there are people who don't know about the option of 1.5. I mean, to be honest with you, I like hit the button like, whoa, this is awesome. And no my baseline for everything is 1.5, which is weird when there's like music on podcasts. It's like very different. But
Maybe go ahead.
I was gonna say our jazz piano intro sounds it slaps different at 1.5.
Maybe the most important takeaway for those who are not familiar is speed up the podcast. You'll learn more faster.
Exactly. So speaking of learning more, carpal tunnel. So another common condition that hand surgeons treat. I found this section fascinating about carpal tunnel maybe being a harbinger of systemic medical problems. So we've read a lot recently about the association between amyloidosis and carpal tunnel. How often are you thinking about this? When you see patients?
Um, I'll be honest, I do think about it. I don't regularly biopsy. This, makes me think perhaps I should. I do think about it in older men with bilateral carpal tunnel. I think the value of these studies is that it is, I guess, unfortunately, a helpful reminder for those of us who don't continue to think about things like this regularly. What about you?
I don't think I think about it enough. When it comes, I've had people sent over for this specific reason. So clearly that is different. To send a biopsy. And I've had a patient who was a cardiologist in his 60s who requested that I do this too. Um, you know, One of our partners yesterday, I was operating, across the hall, and the fellow came in and mentioned that they had sent a biopsy. And I don't know, maybe they had just read this article or not, but I mean, it was a patient, it was a classic patient, like in their 60s, male, bilateral carpal tunnel, and so they just went ahead and sent it off. This article that Deb mentions is from Gannon and Ward, and they sent a biopsy from patients who met certain criteria, so men over 50 and women over 60 with bilateral or previous carpal tunnel release. And not all of them had other conditions associated with amyloidosis, and they were offered screening. Half of them accepted having the biopsy, and almost a quarter tested positive for amyloid. I found that fascinating.
Fascinating. And I haven't read the article, and I don't think we read something about amyloid in Journal Club, but I don't know if there's this one. But yeah, I guess the next level question is what then happens? Does it become, a systemic issue in all those patients or not? And maybe the article didn't delve there, but that's the question.
Absolutely. And shout out to Christina Ward up in Minnesota, who was my co-chair for the resident and fellows course a few years ago for doing that work. And then also there was another article that demonstrated that there is a higher incidence of undiagnosed diabetes or pre-diabetes in patients undergoing carpal tunnel or cubital tunnel surgery. So I also find that interesting. I mean, I think that's probably a general trend in our American population, but do you think about this at all?
I don't think about testing. I do think about it. I mean, that one to me is almost more reasonable or more, it doesn't take that much of a stretch to believe that one just because the relationship's there and maybe we won't be talking about this just like we don't talk about rheumatoid anymore once all these weight loss meds take center stage or continue to advance. But these numbers are crazy. I mean, it's really impressive.
Well, yeah, I found it interesting. I mean, they had a group of patients who had peripheral nerve compression, so carpal and cubital tunnel syndrome. Half of them were pre-diabetic, and 13% tested diabetic on a glucose challenge test that they took, and that's double the control group. So of people who don't have carpal cubital. I mean, that's just interesting. Because oftentimes we'll have patients say, "Why do I have this?" Like referring to carpal tunnel or trigger finger, and maybe this is something that just adds to the counseling.
Yeah, maybe we need to be more than just hand surgeons, Chris. I mean, we got to think systemically, like we're back in med school.
I remember when I was doing my internal medicine clerkship, and it was back in the day when we still had grades, and you had to crush every rotation, right? And really ace it and make the medicine people think that you would be the best medicine doctor. And I did that, and I remember doing a debrief with the clerkship director hardcore internist. And I was like, yeah, I'm gonna be the orthopedic surgeon, knows their medicine and all this stuff. And that lasted for about a year in internship. And then after that, it was like I tried so hard. I tried really hard to optimize things, and I was like, okay, consult medicine.
So this next study is a systematic review of carpal tunnel outcomes, Journal of Hand Surgery, Myers et al. And it's that one I thought is incredibly interesting as well, looking at recovery of the APB. What were your thoughts?
Yeah, I mean, I think I've never routinely ordered post-operative electrodiagnostics unless I believe there's an issue. And honestly, for isolated carpal tunnel, I typically don't order preoperative electrodiagnostics. But I do tell people if they do come in with electrodiagnostics, or I get it for other reasons, that if you have an absent CMAP, it is a poor prognosticator. I mean, it's essentially that there is very minimal functioning nerve fibers getting down to the thenar muscles. Uh, what I found interesting about this is that there really was no difference for the folks who had a CAMETS done versus not having a CAMETS. And I actually believe that because, we see so many people with advanced carpal tunnel syndrome, and I very rarely am indicating a CAMETS, which is a transfer of the palmaris longus tendon to improve palmar abduction. I very rarely indicate that surgery in somebody who has compressive neuropathy. It's usually for a traumatic injury.
Yeah, a lot to unravel. I agree with you. I think one of our partners likes the Kamets more perhaps than I do. Some would argue it's not an opposition transfer, but it's really an abductorplasty. I'm trying to show that on YouTube, where essentially you are maximally abducting the thumb to a resting position. So it puts it in a better position. It's not usually as dynamic as as other transfers can be. But the concept of CMAP recovery in patients who had lost the CMAP is interesting to me. It's unexpected to me.
Yeah, it's interesting. I also find it probably less clinically relevant, to be honest with you, just because they're really not going to get their thenar muscle bulk back. I think the reason, and I'll pivot back to the thing that I thought was interesting about this paper was the Kamets thing, because so one of our partners thinks that it is a dynamic transfer as opposed to it's classically described as a static transfer. So I think the reason behind why people don't really need a CAMETS, or the lack of benefit of a CAMETS, is that patients over time develop ways to position their thumb as their carpal tunnel nerve, their median nerve, is burning out, and they don't realize it. Because when I examine people, and this is what I teach our learners, is that you watch the patient abduct, and they will almost always extend their wrist and kind of flex, and then they'll go for extension and flex it down. And if you really watch them, if they'll fire their palmaris as they're trying to position their thumb. So then if you stabilize or flex their wrist down and take away their ability to use their forearm muscles, including the specifically the palmaris, they will be much weaker when you test their palmar abduction. So I think patients compensate over time, and then there's so many other ways they can compensate with their APL, with their EPB, even to position their thumb. So that's why I don't think it makes a difference.
Yeah, really well said. And it does resonate with me in a different population, that is kids born with a hypoplastic thumb. Some hypoplastic thumbs are really difficult to detect. It could be really a minor decrease in size, but there may be a decrease in the APB and thenar muscle size. And I'll see some of those kids at age 8 or 10 who've not been previously diagnosed. And while occasionally we'll operate on them to give them an abductor, many times we don't, because they've figured it out and it's not a real functional issue in ways that are very similar to what you described.
Right, right. So as we bring this to a close, and I think we'll have to do another session on what's new in hand surgery to really get a full appreciation. Um, the patient with atypical carpal tunnel syndrome, I really struggle with this because, while I have a hunch sometimes that it is carpal tunnel, or doing a carpal tunnel release might help, it always makes me nervous. No pun intended.
You're happy when you're nervous. Um, yes, I do believe there's atypical carpal tunnel. I think this author doesn't believe in complex regional pain syndrome. And so the report on 35 hands and 22 patients over 8 years with inexplicable hand allodynia and lack of active finger motion, that's atypical for sure. And to me, it means something very different. In the United States, we would potentially call that a type 2 CRPS if there's the right background, et cetera.
Right, right. But I mean, in a way, the way that in a way that this author, which I always love a single author paper, so shout out to Paco Del Pinal for doing that again. But they had a painful Tonell and a positive Phelan's test. So I mean that is a strong indicator. I mean, I do pump the brakes on a lot of these patients. I will get testing in this situation, and I typically will do a diagnostic injection. I mean, what's your approach to that?
Um, yeah, if it just doesn't strike me that I can reliably predict the results, one of two approaches. I will offer an injection for sure, and I'll lay more crepe, so to speak, about expected outcomes. I might share that I tell the classic carpal tunnel patient that there'll be an 85% cure or near cure rate, 10% of people better, but maybe not cured. I don't say the same numbers. I tell them your numbers will not look like this, even though I'm optimistic the surgery will help you.
Right, right. I tend to tell them that I think we're going to make a difference here. I don't think we're going to fix everything, but I think it'll be a big bite out of the apple, so to say. And Paco's paper here shows that the patients who had these issues with limited finger flexion went from a DPC of 3.7 to 0.3, which is impressive. And, their dash scores improved, their pain and swelling resolved. I mean, that's impressive, and it's certainly something to keep in mind. And I agree, this is a population that we would typically, fall into a CRPS type 2 in the right setting.
Yeah, and I will say that for those of you who, see the same thing and would call this CRPS type 2, again, in the right setting, post-distal radius fracture, post-trauma, whatever, the DPC improves, but it does not, our experience has not been what Paco's was, which is immediate improvement to a near perfect DPC. It is a slow process that takes time and therapy, and my patients do not typically get 100% of their DPC back.
Completely agree, and thank goodness for our therapy colleagues who are able to work with our patients so much to get them there. But I agree, they typically will get there, but it is not instantaneous.
Wow, we did not get a lot of this article covered. We're definitely gonna have to come back.
We really veered off with the trigger finger discussion. We really went off the rails. So yes, we will come back and do it again.
All right, safe travels, and I'll see you when you get back.
All right, sounds good.